Here we have MRI of the lumbosacral spine on 40-year-old with history of right-sided sciatica. So what I want to show here is the abnormality at this L4 and L5S1 level, how to describe it and how to infer and what to do with this patient. So at L5S1, the disc is dehydrated with old annular fissuring, and on the axial, what we see here is annular fissuring and a small central posterior disc protrusion. And as I come laterally and slightly superiorly, there is an ill-defined area of heterogeneous abnormal signal in the right lateral aspect of the central canal. And if we look on the sagittal sequence, this abnormality is extending superiorly along the posterior border of the L5 vertebral body in the epidural space. So what is this abnormality? So there are two possibilities. One is abnormality of the disc which is causing superior migration. So that is right paracentral large disc protrusion with superior migration. The differential would include a primary epidural mass which needs further evaluation with post-contrast examination. If we look carefully on the axial sequence, so here is the central posterior disc protrusion, and as I go, this particular abnormality in the right paracentral region appears to be in continuation with the disc on the axial and also appears to be in continuation with the disc on the sagittal. So between the two differential diagnoses, the most likely diagnosis would be a large right paracentral disc protrusion with superior migration. So what is this causing to the spinal canal? So here the thecal sac is pushed posteriorly and is causing a mild crowding of the nerve roots in the right side of the thecal sac and also causing a severe impingement on the traversing right S1 nerve. If we look on the exit foramina on the sagittal T1 and sagittal T2, the exiting right L5 nerve is not impinged. So based on this, I would conclude this scan as at L5S1 there is diffuse disc bulge with old annular fissuring and central posterior and protrusion with superior migration resulting in mild crowding of the nerve roots in the right side of the thecal sac and significant impingement on the traversing right S1 nerve. Differential of a primary epidural tumor is less likely, but I would recommend a post-contrast MRI for further evaluation. I would ask this patient to be referred urgently to the spinal surgical team and proceed from there. So in summary, here I have got a case of right paracentral disc protrusion with superior migration.